I can't with that. It's like, oh no. No, I You're welcome. Yeah. I have not heard good things. I don't great with like the O's and zeros. That's pretty clever. I mean, like that. I don't know. Like, yeah, when I'm going to class, like he's in a lecture. Yeah, getting really. That's my separate. It's sitting in my I want to try. What was the last worksheet that we did? Today. I didn't even have time to put that. I never do. I took that. Which station was that? No, and then my notes, I know I want to write, and I'm like, I fall out every like couple months. Oh, they're the same. Yeah, they're like itty bitty little like rubber bands. Right after, like they're no bigger than pet rice and other they look like. Remember those? You remember? No, like when they fall out, like those little beans. You put them on it, especially like they flour and there's different colors. I don't know. Yes, you do. Yeah. You know, I would say
Hello. Hello. Not working. Oh, there it goes. Hey, come on, computer. All right. All right. Okay, gang. Good evening. Hope everyone had a stellar spring break. Welcome back. Thank you for bringing the nice weather back with you. Much appreciated. We drove to Indianapolis on Friday to watch our youngest daughter play tennis. And I don't know what it is with parents coming to watch their kids play tennis, but she played horribly. She stunk. She was terrible. And she was very embarrassed. And part of it, I think, is that she has been dealing with a tennis court covered in snow. So she hasn't been able to really play much. And when she doesn't play, she gets rusty. And I think that's frankly probably what happened. So but it was good to see her. But it was 29 degrees in Indianapolis. We're trying to stand there and we're just trying to stay warm. And it wasn't easy. So I'm very glad now to see warm weather. I see some people in shorts. And yeah, hey, might as well 60 degrees. I'm liking this. Yes. Greenville University. They played at a place that I never heard of, Franklin College. You ever heard of Franklin College? Neither had I. Don't know anything about it, but they have a tennis team. So she played, yeah, Haley? Yeah. Oh, okay. So you have a stake in that sense. Anyway. Okay, we are going to finish our discussion of antibiotics. We'll move into antifungals and then antivirals. After that, y'all get the antiviral handout. Yes, I left off the monoclonal antibodies that are used to treat COVID-19. They're very new, but I will talk about those when we get to those. Do you guys know Emily West, any of you? Emily, I was joking with her on Facebook. It's just a joke. She made cookies and said, I ate a cookie I made. I felt really guilty. And I said, well, Em, you made the cookies. You should at least have two. If you're trying to get rid of them, invite me over. I'll have them. And then she said, well, for a price, sure. To which I said, well, a couple of bucks a cookie, why not? And so then she shows up at my office today with a plate of cookies. So you can have some of these for the break. They're a little crumbly, but they're pretty good. So enjoy them. Let's see. Emily had a question about the case study. Did you guys get a chance to look at the first case study yet? It's hard. Were you able to do it? You finished it? Can you guys get it done by Friday? No? Victoria says no. Okay, how about a week from today? Can you get it done by a week from today?
We will on the exam a week from today.
A week from today. Okay, a week from this coming Wednesday. Okay. Okay, guys, read it carefully, because if you don't read it carefully, you'll be led down the primrose path on that one. So there's a drug-drug interaction, then the drugs get switched. So the drug-drug interaction is going to change. You have to figure out how they're changing. So it's very easy to assume that it's one thing when in fact there's a little fake out in that one. So give it a careful read and discuss it with each other, and then you'll figure it out. Sydney. Oh, please do. Please do. Yeah, absolutely. You can come see me. Office isn't off limits, many choice the imagination. Please come see me. I get to see your smiling faces. Well, behind a mask. So, all right. I graded a bunch of chapter 4s. Some of you guys are giving me Shakespeare for the parts of a syringe. Okay, you don't need to give me Shakespeare on the parts of a syringe. One of you probably copied a whole something out of a textbook. No, just give me the Reader's Digest version. Okay, just, yeah. I'm being, if you have everything there, I give you full credit. I'm not looking for mellifluous expression or correct punctuation or something like that. I just want a correct answer. All right. Let's see, what else? Some of you had trouble with chapter, I think it was 6. Yes, I looked at 6 and I redid the due date for a few of you. Anyone else having trouble with 6? No? So just a few of you. Some of you, one of you emailed me and said your score got dumped. And I went in, I looked at it, and yeah, you've got one score, then you have another score that's just a 0. Why it's taking the most recent one, I don't know. It's supposed to take the highest one. That is a little goofy. And if need be, maybe you still had another shot at it. If need be, I can extend the due date on that one for you as well. Morgan? Why can't you see your grades on that?
Like on the regular student, if they play out.
Yeah.
This is like the instructors can have it available for you. So if you don't know, like, you just kind of like guess, like if I'm sent by now, like, and we don't know until after.
You're supposed to be able to see your scores right after.
Yeah. Only on the
All right, I'll check that one again too. Sometimes when I tell it to do something it doesn't behave. So yeah. Right. Did you guys not know that? So to see it on Blackboard, you have to get out of the website. And oh, the ones that I'm supposed to grade. Okay. You're supposed to be able to see them right after you do them. Okay. I'll check that one too then. Right. Okay. Right. I'll have a look at that then. All righty. Let's see. We are on the tuberculosis drugs. That's where we stopped last time. Page 7. Okay, let's have a word of prayer and then we'll begin. Lord, we are so thankful for a nice break and for nice weather, for sunshine, for temperatures above 50, and for every student here. Thank you that they are here, that they're healthy, that no one seemingly is on quarantine. Lord, protect them as they walk into clinics and learn from preceptors and what have you. Let them be salt and light wherever they go, and help them to learn this craft of nursing, because it is a craft. Thank you for their dedication to it. We pray now, help us dedicate to learning about these medicines for infections. In Jesus' name, amen. So with tuberculosis, you'll virtually always have combination drugs that the patient will be prescribed. If they have a typical strain of tuberculosis, that is, it's not drug resistant or even multi-drug resistant, they'll be treated usually with these 4 drugs: rifampin, isoniazid, and ethambutol, and yeah, usually those. The isoniazid, because that's the only drug that's effective for latent tuberculosis, they'll need to be on that one for 6 to 9 months. And if they have a weak liver, that's going to be a challenge. So rifampin is very important for any typical tuberculosis, antituberculosis cocktail. You never treat rifampin as a monotherapy simply because the drug inhibits RNA polymerase. RNA polymerase. Who can tell me what RNA polymerase makes? Messenger RNA, and in bacteria, the same enzyme makes tRNAs, also in ribosomal RNAs. In eukaryotes, there's different enzymes. But because it binds to the active site of the enzyme, single amino acid substitutions can prevent the drug from properly binding to it. So because of that, resistance to rifampin can occur at a relatively high rate. That's why you treat with another drug to make sure that the resistance doesn't occur at high rates. So you treat with rifampin and isoniazid. Isoniazid prevents the synthesis of mycolic acids. So the cell wall of Mycobacterium tuberculosis, really all mycobacteria. Remember we did that acid fast stain? You boiled the carbol fuchsin into the cells. It was really messy. And it was that the cells were pink, kind of a pretty pink color. Some of you remember. That dye stains those cells because the cell wall is very waxy. It's very water hating. If you put mycobacteria on water, they float. They have a very waxy cell wall. So they have these lipids called mycolic acids. These are long branched fatty acids. The mycobacteria cannot survive without mycolic acids. Isoniazid prevents the synthesis of mycolic acids. Now, isoniazid, interestingly, it's a prodrug, but it's not activated by you, it's activated by the bacterium. So the bacterium will activate it using a catalase peroxidase hybrid enzyme called CATG. It turns it into a reactive species that then inhibits the enzyme that makes mycolic acid. So it's very specific for mycobacteria. So it will not kill off your normal flora. That's one of the beauties of isoniazid. Okay, biggie with this one is peripheral neuropathy. Peripheral neuropathy. So if your patient has diabetes and they're prone to diabetic neuropathy, or they have some other neuropathy in general, they've been on chemotherapy or something like that. Chemotherapy patients sometimes will have neuropathy either in their feet or their hands or something like that. Then you need to check for neuropathy. What's a fast test you can do for neuropathy? Yeah, Morgan, you go ahead. Yeah. So you can just take the hand. You can take your pen and just have them look away. And do you feel that? Do you feel that? Do you feel that? Did you? And just something like that, and then kind of work like that. And then you can do the same thing with the feet. You can do the tuning fork. You know the tuning fork thing on the feet? Yeah, tuning fork on the feet. That's for pressure receptors and things like that. Those tests are not hard. They're very easy to do. Now, turns out with isoniazid, if you supplement with vitamin B6, that can keep the neuropathy at bay. B6 comes in several oral forms. There's also a sublingual form of B6 if they have trouble swallowing pills. So this is available. It's cheap. It's out there. Suggest it. Well, don't just suggest it. Say, you really should take this with the isoniazid. It does not interfere with the efficacy of the isoniazid. So have them take that. Now, the other that's uncommon but can happen is optic neuritis. Optic neuritis. So you're going to check visual acuity. How do you do that? Sarah, how do you do that? Yeah, the chart. What's it called? Snellen eye chart. Snellen eye chart. Read this line, and so check their eyesight before they go on it, record it. Then, when they have their follow-up, check it again. And if it's the same, you're probably fine. If it's changed, then you need to have an ophtho consult because they need to have their retina checked. Seizures, rare. Seizures usually only occur in people who are already prone to seizures. So if they're on any medicines that drop the seizure threshold, like bupropion or something like that, then you need to be concerned about seizures. If they have a seizure, you're going to need to pull the drug. Well, if you're a prescriber, definitely tell the provider. Drug-induced lupus has been reported, but it's very rare. More often, it's the case that people who have lupus, the isoniazid makes their lupus worse. 5, some people have hypersensitivity to isoniazid. If they've never been on the drug before, they may not know it. They start on it, they get a rash. It's clear, it's due to the drug. You pull the drug, call the provider, and the provider will have to use something else. Okay. Isoniazid is the drug of choice for latent tuberculosis. Rifampin only works on active tuberculosis. That's why rifampin, usually you only give for the first 1 or 2 months. As the drugs drive the tuberculosis into the latent phase, isoniazid will continue to hit the latent tuberculosis. Now, isoniazid, remember in the liver, you have phase 1 and phase 2 reactions for drug metabolism. Stretching your memory here a bit. What's characteristic of phase 1, phase 2 reaction? Bless you. Who can tell me, bless you, who can tell me about phase 1, phase 2? Phase 1, let's do phase 1. What's characteristic of phase 1 reaction? Some of you are looking down, which means don't call on me. What enzymes mainly execute phase 1 reactions? Cytochrome P450, say it again. Cytochrome P450. So these are oxidation reactions usually. They can be reductions too, but they're oxidations. They may result in loss of a methyl group, loss of an amino group, something like that. Phase 1 reactions. Phase 2 reactions. What are those characterized by? Transferases. You attach big charged molecules to them that makes them more soluble. Usually, phase 1 reactions occur first, phase 2 reactions occur second. Isoniazid is an exception, just like acetaminophen. Phase 2 reactions occur first. So you acetylate the isoniazid, it gets broken down. It gets broken down to a compound that's hepatotoxic. Now, the liver can handle it if the isoniazid is acetylated at a modest rate. There are some people who are fast acetylators, and isoniazid will cause liver damage in them. How do you know? You may not know. So that means you're going to check liver status, like a hawk, especially for the first month or so. How do you do that? Liver panel, right, liver panel. Patients must not drink alcohol while on this drug, bless you. Someone need a COVID test? I was kidding. You drink alcohol while you're on isoniazid, you then will present for a liver transplant. It will kill your liver. So that must be emphasized on top of B6 and whatever else. And again, tell the patient you're going to be on this drug for a long time. You must take it every day. You must take it every day. If you don't, you're selecting for resistance. Then you'll be in really deep weeds. Oh, it makes me feel awful. If it's not damaging your liver, you need to stay on it.
So say that they forget a dose, they double up on the next dose?
No, just continue to take it. All right. Ethambutol is also first line for tuberculosis as well. This inhibits the synthesis of complex carbohydrates in the cell wall. So it's another anti-cell wall drug. This is a really good drug. It's well tolerated usually. The issue is that it can cause some optic neuritis. It's reversible, but your color discernment tends to go south. How do you test that? Yeah, Ishihara test. The test with the numbers in the background for color blindness. if they can pass that, now if they're colorblind to start with, then that's a little tougher. There are color discernment tests for colorblind people, and ophthalmologists will have them. But every hospital I've seen has an Ishihara test sitting around somewhere, or the doctor's office. Just pull it out, make sure they can pass it before they go on it, make sure they can pass it while they're on it. If they fail it while they're on it, then they've got an issue. Now, because of that, you don't use this drug in children, because children have a rougher time passing color acuity tests. Some people get a rash, some people get a drug fever. That is very uncommon. On the average, this drug is well tolerated. Next drug, pyrazinamide. Pyrazinamide. This has a mode of action that's similar to that of isoniazid. It inhibits the synthesis of cell wall specific fatty acids. It's not specific for mycolic acid, tends to be fatty acids in general. So this drug is only active against active tuberculosis. That's why after 2-3 months, you'll pull this drug and just have them be on isoniazid. This drug, when it's taken up by the phagosome, it gets concentrated in the lysosome. In the acidic environment of the lysosome, the drug is activated. If you give this drug with rifampin, you increase the hepatotoxicity of rifampin. So don't give it with rifampin. Give it instead of rifampin. Oh, another thing about rifampin I didn't mention. Rifampin is a major league inducer of several cytochrome P450s. So rifampin will cause a lot of drug-drug interactions. One of the worst is oral contraceptives. Because it induces cytochrome P450, you'll get contraceptive failure on rifampin. Because the drugs are being chewed up faster. And it's not just those, other drugs too. Rifampin, it interacts with cytochrome P450s, it induces cytochrome P450s. That means drugs that are metabolized by those cytochrome P450s, their half-life now goes way down. So you'll have to adjust the dose of other drugs that interact with rifampin. You might have heard that antibiotics can mess with oral contraceptives. Have you heard that? That turns out to be a lie for most antibiotics. The exception being rifampin. It will interact with rifampin. Won't interact with amoxicillin, won't interact with fluocinolones, won't interact with a lot of these others we talked about, but it will interact with rifampin. You'll get treatment failure. Okay, those drugs are used for standard TB. TB that is not drug resistant. Not drug resistant. If you have a drug resistant TB, now you start going to these other more unusual drugs. So this drug, pretomanid, has a mode of action that is not completely well understood. The beauty of pretomanid is that it doesn't have any cytochrome P450 interactions. This drug was developed by a consortium called the TB Alliance. And in fact, there's a scientist at U of M who was part of that consortium that helped develop this drug. This drug, again, is very specific for mycobacteria. It will not kill off your normal flora. The biggie with this one is that it can cause QT elongation. If you get QT elongation, that means you can get torsade de pointes. Torsade de pointes is potentially life-threatening. So you're going to watch their EKG like a hawk. And if they come in to the doctor's office with a really fast beating heart and an EKG with that torsade de pointes looking a thing like that, how do you treat torsade de pointes? Oh, gang, you need to know this. Magnesium sulfate. Magnesium sulfate IV push. IV push. 1 to 2 grams in 30 to 60 seconds. Maybe repeated every 5 to 15 minutes if needed. Magnesium sulfate. They need it and they need it now. This is life-threatening. So with drugs that elongate the QT interval, there's a risk of torsade de pointes. Torsade de, oh, okay. Yeah. Yeah, so I don't know what you guys don't know. Or I don't know what you do know either. So if you don't get a buzzword, let me know, okay? I will spell it. Torsade de pointes. That's a D. D. Huh? Okay, fine. Okay. Torsade de pointes. So with this, if this is your isoelectric line, so normally you're going to have a P wave, QRS, and then a T wave, or something like that. With torsade de pointes, you get this, like that. The torsade de pointes means twisting of the points, twisting of the points. So the dipole gets twisted. And if you have a elongation of the Q to T interval, if that gets elongated, you're at risk for developing the torsade de pointes. There's some drugs that cause this, some do it in a dose-dependent fashion. Erythromycin, for example, will do this in a dose-dependent fashion. So will loratadine. Now, it takes very high doses of loratadine to do that. Also, there are some psychiatric meds we'll look at to do this. Ziprasidone is the worst offender of the antipsychotics. And clozapine is supposed to do it, but there was a report that came out that said clozapine actually doesn't. But the other one is thioridazine and olanzapine, but that's dose dependent. So with this drug, be careful of the torsade de pointes, because if that happens, that can they're going to have a very fast heart rate. You'll hook them up to an EKG, and you get this doingy, doingy, doingy thing that doesn't look anything close to normal. All right. It is metabolized by cytochrome P453A4. So if you have drugs that induce or inhibit that enzyme, you'll get an interaction with this drug. These others, headache, dizziness, nausea, tend to be limiting. They're not, it's not a huge headache, it's not huge nausea, it's not huge dizziness. They tend to be pretty self-limiting. They do occur commonly, but they're not huge. Okay. Bedaquiline. Bedaquiline is this duraquinoline. This inhibits the mycobacterial ATPase. Mycobacterial ATPase. So that proton pump that pumps protons back into the cell, it spits protons out, the electron transport chain spits them out because it sends the electrons down to oxygen, combines with oxygen, molecular oxygen to make water. You get protons that get pumped across the membrane. Those protons then come back in. The ATPase will let it in, but then it makes ATP as it does that. Why am I getting blank stares? You guys, this is how cells make ATP. Yes, thank you. Good. Okay. Some of you are, yeah, some of you giving these blank stares thing. This will inhibit that ATPase in the mycobacteria, and it does so specifically. This drug was designed because people did very detailed crystal structures of the mycobacterial ATPase, and then they did design drugs that fit into that ATPase, but wouldn't fit into the human ATPase. Pretty clever, huh? So this drug is pretty new, goes by the name Saturo. This you'll only use if you have a multi-drug resistant TB. So this causes headaches, chest pain, nausea, joint pain pretty commonly. Serious side effect, again, QT prolongation, which puts you at risk for torsade de pointes. There may be some liver dysfunction, so check liver function, check EKG, increased risk of death. Because again, these people tend to be very sick. Contraindicated during pregnancy. Don't give during pregnancy. Also, cytochrome P453A4 inducer, substrate. So those who take a 3A4 inducer or inhibitor shouldn't take this drug. Also, if they take another drug that elongates the QT interval, they shouldn't take that with the bedaquiline. Yes?
So would you say with all these drugs,
Except for ethambutol. Ethambutol is not damaging to the liver. Most of the others, yeah. And the issue too, Sydney, is they're going to be on them for a while because these treatments take 6 to 9 months. For the drug-resistant ones, they may have to be on the drugs for 2 years, depending on how sick they are. So yeah, just check the liver routinely. Usually, the doctor will usually suggest you come in after the first month, and then if you're fine, he or she will then say, okay, 2 months, and then usually for another 4 months, and then 6 months, and then after a year, usually, because if it causes liver damage, tends to cause liver damage usually towards the beginning, unless you drink yourself into a stupor, then yeah. But I mean, this is assuming your patient doesn't do something stupid, which patients are human, so they do sometimes. So, and you being the nurse get to pick up the pieces sometimes. So, way it goes, comes with the job. And then other drugs, so like ethambutol, they need to have the eye exam. Isoniazid, they may need to have an eye exam just to make sure they don't have neuritis, things like that, and what have you. And then if they're on other meds, you need to make sure that you don't have interactions with those other meds too. That's the other thing you're looking at. Or side effects due to the meds. Yeah, Emily?
so do they give you like prophylactically, like if you have an exposure?
Yes, yes, but the prophylactic exposure is just isoniazid and rifampin, and that's usually for only 2 months.
Okay.
They'll also give those to workers sometimes who go into tuberculosis heavy areas. So, for example, Médecins Sans Frontières, Doctors Without Borders, they go into these TB hotbeds. Sometimes those people, the doctors and nurses, they pre-treat them with rifampin isoniazid before they go in. So that's a great organization, by the way. If any of you want to do overseas humanitarian work, that's a terrific organization to work for. Not a Christian organization, but they do some really good work, and they have access sometimes where other organizations don't. So very good organization to work for. Okay. Questions about fluoroquinolones were also used against TB. They're effective against TB. They're also used as well. Then there is another aminoglycoside called capreomycin. Capreomycin, that's also used. That is usually just used for drug-resistant tuberculosis. Streptomycin is just not used that much anymore. Streptomycin, the side effects are just, they're hard to manage. You lose your hearing, it's just, yeah, so, no. All right, are there any questions about any of the antibacterials we've covered before we go on to the antifungals? Okay, please turn to page 10 then. Let's take a look at antifungals. I think I said this about chloramphenicol. I'll just say it again. 8 o'clock tomorrow? Yeah. So chloramphenicol, remember, causes aplastic anemia. It causes aplastic anemia about 1 out of every 5,000 cases. You don't use it for human medicine unless the situation is dire. And even then, you use it very, very cautiously. It's used for veterinary medicine. So sometimes people get sick and they take their dogs chloramphenicol. Not a good idea. So if they do take chloramphenicol, you need to make sure that you're checking the bone marrow function. So you need to be doing CBCs on a regular basis. So yeah, that's the only time you use chloramphenicol. Most doctors I've known just won't use it. So, all right, antifungals. Okay, the first group, remember, fungi are eukaryotes. So now the drugs you're going to use for fungi are going to typically be a little more toxic because they have a eukaryotic cell type just like we do. So the things to attack in fungi are, number one, the cell wall. Because to our cells, the cell walls? No. So that is a target for antifungals. The other is that instead of cholesterol in the membrane, like we have, they have another sterol called ergosterol. Ergosterol. And ergosterol synthesis or ergosterol in the membrane are potential targets for antifungals. Ergosterol is a little bit like cholesterol, but it's not cholesterol. And fungi need ergosterol in their membrane in order to regulate the fluidity of the membrane. So the first drugs, polyenes, the polyenes, they attack ergosterol in the fungal membrane. They bind to it and they form a pore. That pore causes the cell to leak and the cell dies. That's how the polyenes work. So the first of these is nystatin. Nystatin is only used topically. It's not used systemically, only used topically. It's very, very effective for candidiasis. So Candida infections, very good for that. The other member of the polyenes is amphotericin B. That's the one that binds ergosterol, forms a pore, it leaks. However, amphotericin B, while it has a higher affinity for ergosterol, is not completely selective for ergosterol. It will bind cholesterol and damage our cells. So the biggest issue with amphotericin B is nephrotoxicity. Because this drug is toxic, tends to be used in dire cases, like fungal meningitis. That's usually when you'll use it. All right, so the first side effect, it's rather notorious for its renal toxicity. You get wasting of electrolytes. There are lipid formulations of amphotericin B that are less nephrotoxic. Less nephrotoxic means going from here to here. That can be a big deal sometimes, but they're still nephrotoxic. Now, another feature of this drug is given intravenously. Infusion reactions are very common. When it goes in, the patient will get very, very chilled. So, you're the nurse. How can you handle this? A heated blanket. So, patient's going to get this. Hospitals have blanket warmers. Make sure you order a heated blanket, have it ready. They get chilled, you throw the blanket on, you're a hero. So, I want you to write next to that, heated blanket. Yes. What only? For nystatin. Yeah. Oh, nystatin topical. Oh, did that go down? Right, for nystatin. That's the case for nystatin. Yeah. Only the case for nystatin. Now, you can also pre-treat the patient with hydrocortisone or acetaminophen. That tends to take the edge off it. But still, having a nice warm blanket on hand is a good idea. All right, you use this for cryptococcal meningitis usually. Cryptococcosis, you usually see in immunosuppressed patients, but you may also see it in children. You get this fungus from pigeon dung. And you can also get it from caves where there's lots of bats, because it's in the bat dung as well. So if you go into a cave where there are lots of bats, good idea to wear a mask. Yeah, you inhale it, you usually get a pneumonia. It's usually, some people, asymptomatic. The organism has a predilection for the brain because it has a phenolic oxidase system, and it then enters through the cribriform plate, usually, or usually through the chorionic villi, and gets into the brain, and it can cause a very fulminant meningitis. When it gets to that stage, you need to treat with amphotericin B. Yeah. Okay. Break time. We'll do 5-fluorocytosine, which is not a polyene. Then we'll go to the azoles. and then the echinocandins, and then we'll hit the antivirals. So if you'd like a cookie, please have one. Chocolate chip. And they're even in pieces if you don't want a whole cookie. So you're very welcome. They're deformed. Were you guys vaccinated against COVID-19? No? I thought you guys would have been because you're working either near patients or with patients or. Okay. Because my wife works down at the Oaks and she got vaccinated since she works with elderly patients. College professors in terms of importance are down, you know, near dirt. So we won't get vaccinated probably till next Christmas. Which is too bad. Yeah, sure.
I'm not even kidding. Like, is that okay?
You're not sick by now, you're probably fine.
Okay, well, I would have known.
Yeah, I don't think so.
Okay. When you said it, I was like, wow, what a coincidence. It was before we went, so on paper, it's like, oh, they come down and like, it's out of that. Well, no, it was fun, but I don't know if it was worth it.
Caves are amazing ecosystems.
Yeah.
They really are. They're amazing. They're just amazing.
It was fun that like hundreds of years ago, like it was like hieroglyphics.
Oh wow. That's cool.
I didn't want to do that.
Yeah, no, that's pretty cool.
No, I was thinking this one. What was that? Don't worry about it. Dr. Bean, have you ever been shot by a bird?
I ever what?
Down by a bird.
Pooped on by a bird, yes. When you live on a farm, it's not hard. Sydney, we raise sheep. Sheep are as dumb as a post. They really are. They're dumb. Yeah, okay, yeah. So they, you name it, they'll do it to you.
My mom got put down with it twice naked. Because my sister got naked with one time and both times she got put down.
Yeah. Do you, when the pigs are born, do you grind their teeth?
So the pigs are born in Allegheny County. My dad has a friend out there who has them. And then when they get to a certain age, we bring them back up to our house in Allegheny County. And they have them like that. So by the time we get them there, we have not to.
Okay,
I'm assuming he does.
because if you don't, they'll take bites out of each other.
Oh, yeah. We have a bowling ball we stick in their pen to like get their neck muscles. So like they act like dogs for the first couple months and then they started running their own.
Baby pigs are ugly, but they're cute.
Yeah.
They're kind of like bulldog puppies. They're just ugly, but they're cute.
I've seen these pictures. My sister's written before.
Yeah. Yep. I did 4-H. Okay, let's get back to antifungals. 5-fluorocytosine. We will also see when it comes to, I have to see the piggies.
Big one.
Good night.
My sister named one Lindsay Lohan.
I
And then here's another one. His own name.
That's a face only a mother could love.
Yep. Lindsay Lohan.
All right. Now, 5-fluorocytosine is never to be used as a monotherapy. You always combine it with other drugs. Same reason. With rifampin, the chances of mutations that prevent the organism from being inhibited by it increase. 5-fluorocytosine is led into the cell by a transporter, a permease. If you obliterate that permease, the cell is no longer susceptible to this drug. So I use this drug with something else. So this gets converted into metabolites that will interfere with the synthesis of nucleic acids, DNA, RNA, things like that. It gets converted to 5-fluorouracil, and then it gets incorporated into these nucleic acid and makes bum nucleic acid, and it tends to inhibit DNA and RNA polymerases. So this is very good when combined with amphotericin B. It potentiates the activity of amphotericin B. It's also useful with Candida species, particularly if you combine it with something else like nystatin or something like that. This drug will cause bone marrow suppression, so you don't want them to be on it too long. So check CBCs to be sure. GI disturbances, they tend to be common, but they're not too severe usually. You get your worst GI issues when you first go on the drug, then the patient usually gets accustomed to the drug and it's usually not an issue. Some people just have sensitive stomachs and they may just really have trouble. So consider that. Okay. Never use the monotherapy. Check hematology to determine toxicity. It's used in combination with A and B. That means amphotericin B. That's 5-fluorocytosine. That drug is oral. That drug is oral. Azoles. These are your mainstays of antifungal treatment. So these drugs inhibit the synthesis of ergosterol. In humans and fungi, Lanosterol is converted to a metabolite that's then converted to either ergosterol or cholesterol. That step is the same in humans and fungi, but the enzyme in fungi is different enough so that's inhibited by azole drugs, and those azole drugs don't inhibit the same enzyme in humans. So that enzyme is called the 14-alpha demethylase. It's a cytochrome P450. And azoles inhibit that enzyme in fungi, but not in humans. So whereas amphotericin B latches on to ergosterol structurally, azoles prevent ergosterol synthesis. They prevent ergosterol synthesis. Now these, you notice, end in conazole. Conazole. If they end in conazole, they are an azole. Azoles. So these, clotrimazole, mazole, micon, azole, ketocon, azole, flucon, azole, those are azoles. These two are just used topically. This one is broken down very quickly if you give it systemically, so is this one, but they're still very useful topically. Both of these are available over the counter. You may in fact recognize those brand names. And they're used typically for yeast infections. Diflucan is the oral treatment for vaginal candidiasis, and fluconazole essentially is given as an oral tablet. You just take one tablet and you're done, essentially. It's very effective. All right, let's take a look at these drugs. Fluconazole is the first one. Fluconazole is very well tolerated. Also has excellent bioavailability. Very effective against Candida. Very effective against Cryptococcus neoformans. It's very good for the respiratory Cryptococcus, not good for the meningital because it doesn't cross the blood-brain barrier very well. Not very good against molds or most dimorphic fungi, but it is active against Coccidioides immigrans. Okay, it's eliminated in urine. What does that tell you? Should tell you if your patient has renal problems, you're going to need to adjust their drug dose for their renal function. It's a weak cytochrome P453A4 inhibitor. So it may cause some drug-drug interactions. Check the other drugs the patient is on. May cause a rash, may cause some liver toxicity. That's usually reversible. So this drug is pretty well tolerated. Itraconazole. Itraconazole is another story. This drug is a very strong cytochrome P453A4 inhibitor. But as you can see, it is very, very effective against most dimorphic fungi. Very effective against Aspergillus, very effective against Coccidioides, Histoplasma, Blastomyces, Paracoccidioides, all those dimorphic fungi, very effective against them. But this drug will do a number on your liver if you have a weak liver. So next to hepatotoxicity, please write, check liver function religiously. Two, bioavailability of this drug is erratic because the absorption is erratic. Take the drug with food. That will help the absorption. 3, causes QT prolongation, but does so in a dose-dependent fashion. At standard doses, it's usually fine, but still, what if they're on something else that already causes QT elongation? Now you have a problem. So what are you going to check? EKG. EKG. Contraindicated in patients with heart failure because of its ionotropy. There was an IV formulation. It's not available in the US anymore. It's been discontinued. I think it's still available overseas. I think, well, no, it is. It's available in India, for example. England, I don't know about England, but it's available in South America. So it is available in IV formulations elsewhere, just not in the States. Yeah.
What
Also,
happens if you don't take it?
you'll have poor absorption. Your drug concentration will be erratic.
Okay.
In that case, then you probably want to do blood draws and check drug levels. That's itraconazole. Next we have, yeah, Sydney. Because the drug is not terribly soluble and you had to give it with lots of diluent. And so you fill your patient up and now they're a threat for hypervolemic shock. And so it was just discontinued. Also, when it was discovered that if you take it with food, particularly if you take it with a fatty meal, the absorption is very good. That was the other piece too, so discontinuing the IV form. Next one, voriconazole. This is a specialist for aspergillus. Now, who gets aspergillosis? If people have had lung resectioning and they have these cavities in their lungs, who else gets those cavities in the lungs? Tuberculosis patients. They're at risk for aspergillosis. So this drug is a specialty for aspergillosis. This drug too can be very hard on the liver. So again, check those liver function tests. Monitor renal function because there may be some renal toxicity too. Some patients get rash. That doesn't tend to be terrible. It tends to go away after the drug is discontinued. Visual effects. Some people start to see wavy lines and flashing. That goes away. Significance of that is not known. Why it even happens is not really known, but it does happen. Warn your patient about it because they'll freak out. I'd freak out. Good point.
Is that like defib, or is it completely different?
That like what?
Like ventricular?
Oh, defib. You said defib. Right, ventricular. With ventricular fibrillation, it's not beating at all. It's just asystole. And so really it's just a more flood. This is actually moving, but it's instead of a nice beat, it's like that. It can go to defib. That's why you need to treat it.
So you would just stop the medication?
Yeah, you stop the medication, then you give them, what do you give them?
Oh, and then
Magsulfate. Magsulfate. IV, push. IV, push. Posaconazole. Oh, voriconazole 2 is a 3A4 inhibitor and a pretty strong one. It's also good. You get strains of Candida that are resistant to fluconazole. Hit them with voriconazole. Works great. Posaconazole. This is good for zygomycetes. Zygomycetes. Zygomycetes include red molds. Oh, for goodness sakes, who gets infections with red molds? People who are immunosuppressed. Cancer patients, HIV patients, people with immunodeficiency diseases, folks like that. This is your drug of choice for those zygomycete infections. This drug comes as an oral suspension, not as a tablet. It must be taken with food. Must be taken with food, and high-fat foods and high pH drinks like soda pop will increase the absorption. If the patient is on some sort of proton pump inhibitor, that tends to inhibit absorption. Nausea tends to be pretty respectable with this drug. And this drug too is a cytochrome P453A4 inhibitor. So DDIs are an issue too. Okay, isavuconazole. This is the newest of these drugs. You use this for life-threatening fungal infections. This drug is pretty toxic. You can see the list of side effects. Serious reactions occurred in half the patients. Back pain, cough, renal failure, peripheral edema, elevated liver enzymes, headache, nausea, vomiting, diarrhea, constipation, blah, 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 blah. Yeah. But it's either that or the fungus kills you. So this is your last stop, essentially, on the treatment. You use this for emergencies. If you use this for emergencies, your workload just went up. You've got a lot of things to check now. So you're going to need to make sure they keep food down. They may need to have a G-tube or something like that. Headache, liver enzymes, you're going to have to check those liver enzymes. Renal, you're going to have to do draws, check electrolytes. Peripheral edema, cough, you may have to help with the cough, back pain. Serious reactions, yeah.
So what classifies like as a situation where you could only get this? Like where you go?
Everything else has failed.
Oh, okay.
Yeah. It's a 3A4 substrate, so don't give it with 3A4 inhibitors and inducers. By the way, these drugs here, ciclopirox, iconazole, these are topical drugs. Most of these are available over the counter. So they're used for athlete's foot or fungal infections on the skin, or some kids get scalp, fungal infections of the scalp. You can use stuff like this. These are over the counter. They're over the counter. These obviously are not. All right, echinocandins. Echinocandins prevent the synthesis of beta-D-glucan. This is a polymer of glucose that's specific to the cell wall of these fungi. These enzymes inhibit that enzyme that makes this glucose polymer. So it inhibits cell wall synthesis of certain fungi. Now, what if you're a fungus and you don't have beta-D-glucan? Well, then these drugs won't work. Fortunately, many fungi that cause disease do. So Candida, Aspergillus, some zygomycetes, Aspergillus, non-Aspergillus mold, no. Cryptococcus neoformans, no. But these others, yeah, they're very effective against these other types of fungi. These drugs have to be given parenterally. You can't take them orally. They're only available parenterally. By and large, they're very well tolerated. Some people get infusion reactions. That's uncommon, but if they're known to have them, you pre-treat with antihistamine. Give them some Benadryl, give them some cetirizine, give them some loratadine, fexofenadine, whatever. That should prevent that. Yes?
These are different than azoles.
Yes, these are echinocandins. They work by a different mechanism. They don't work via ergosterol synthesis inhibition. They inhibit the synthesis of these beta D13 glucans. They're still antifungal, yeah. Some people get hepatotoxicity. It's usually only people who have pre-existing hepatotoxicity. So that's uncommon too. Now, caspofungin, they end in fungin, these. Caspo and micafungin, both those drugs are hepatically eliminated. So you don't have to adjust for renal function for these drugs. Big advantage. Big advantage. And anadulafungin is eliminated in the plasma. So you don't have to adjust for either hepatic or renal function in that case. So they're less active against this one species of Candida called Candida parapsilosis. And you do have drug interactions, unfortunately, with anti-transplant rejection drugs. So sirolimus and cyclosporin are given to patients who've had transplants. These interact with those. And those are the antifungals. Questions? Okay, let's go to our antivirals. Okay, let's do the HIV meds last. So let's go to page 4. Let's do these first. Okay, both hepatitis B and hepatitis C are RNA viruses. Now, hepatitis B does this really cool thing where the viral genome makes a RNA that is then reverse transcribed into DNA. And then it uses that essentially to make more copies of itself. So you have a reverse transcriptase in hepatitis B, just like you do in HIV. So because the reverse transcriptase, do you know what reverse transcriptase is? I'm just assuming. I want to make sure. So polymerases will make RNA. RNA polymerase makes RNA from DNA. You have a DNA template, you make RNA, and then that RNA goes and does whatever the RNA does. Reverse transcriptase takes an RNA template and uses that RNA template to make DNA. That's reverse transcriptase. That's unique to HIV and other retroviruses, and it's unique to hepatitis B. So some of the drugs used to treat HIV also can be used to treat hepatitis B. That's really, really valuable because very often patients with HIV can be double infected with hepatitis B. So you can use cocktails that will treat both with one cocktail. Very handy, very, very handy. So hepatitis C is a single-stranded RNA virus. It's a plus strand virus. That means that the viral genome is a messenger RNA. So we have some drugs here that treat hepatitis B. So this entecavir, as you can see, treats hepatitis B. Now, lamivudine, as you can see there, treats both hepatitis B and HIV. Treats both hepatitis B and HIV. Emtricitabine. Emtricitabine treats both hepatitis B and HIV. And those two can be put together to treat HIV and hepatitis B, and they often are. Okay. Hepatitis B is also treated with a nucleotide analog called tenofovir. Tenofovir. Now, this drug is very poorly absorbed, so the drug companies made a prodrug. There's two prodrugs. So there's this tenofovir disoproxil or tenofovir alafenamide, and the tenofovir alafenamide and the tenofovir disoproxil, those get converted into the active form in the body, and they're absorbed much better. This drug, as you can see, has a gaggle of side effects. I'll let you read those. And then the next one that treats hepatitis B is this adefovir. That one also is made as a prodrug. Now, adefovir can be very toxic to the kidneys. So you want to be careful with renal function on that particular drug. All right. Oh, tenofovir, by the way, is also used to treat HIV. So cocktails with tenofovir and lamivudine and emtricitabine can be used to treat both. Now, what about hepatitis C? There's ribavirin, and ribavirin is very often combined with interferon. Now, interferon is being used less and less because of the oral cocktails that are available to treat hepatitis C that are very effective, also have much fewer side effects than hepatitis B, than interferon. So interferon is being used less and less. But interferons, you can see, there's two types. There's a interferon alpha 2, and it's conjugated to polyethylene glycol. You give that with ribavirin. You have to give it for 24 weeks. And interferon is not very well tolerated. Second one is interferon alpha 2B. That's also a pegylated interferon. Why do you pegylate it? You pegylate it because it has a much longer half-life. What does interferon do? Interferon tells cells that aren't infected to modify their machinery so that they resist infection. So essentially the virus runs out of cells to infect. That's how it drives the virus from your body, by preventing the virus new territory to grow into. And then ribavirin inhibits the replication of the virus. Okay, what about these other drugs that are used orally? Usually you have combination drugs that are given together. So there's a specific hepatitis B protein, hepatitis C protein, called NS5A. There are drugs that specifically target NS5A. NS5A is required for viral replication. And they're listed here with other drugs that they're combined with. Some of these drugs are protease inhibitors, that is protease inhibitors for hepatitis C protease. Others are polymerase inhibitors because hepatitis C makes its own polymerase. So these, the trade names have been given. So Sovaldi is declastivir and sofosbuvir. There's Zepatier or Zepatier if you're using the French pronunciation. That's elbasivir combined with grazoprevir. Then there's Mavyret. Mavyret has this ribatasvir combined with glyceprevir. Then there's Vilsevi. Vilsevi has velpasadevir combined with this voxeloprevir, or the velpatasvir can be combined with sofosbuvir and Epclusa, and so on and so forth. The list goes down. These oral preps are very effective. They completely drive the virus from the body. After treatment of these, with usually, I think it's about 4 months, you have no detectable virus. That was rare with interferon. So these drugs can completely cure you of hepatitis C. Completely cure you of hepatitis C. They're oral, they're very convenient. Interferons had to be given by injection. Not very convenient. So these now are the drugs of choice. And now some of these drugs are specific for particular hepatitis C genotypes. And I will just let you go through and look at those and see essentially these drugs now are they're the drug of choice for this. Okay, let's go now to the herpes and anti-herpes meds. Okay, acyclovir. These drugs inhibit viral DNA synthesis. They get incorporated into viral DNA, but not human DNA, because they're phosphorylated by the viral kinase, but not the human kinase. So they're very specific for the virus. Acyclovir has terrible bioavailability, awful. I think only 35% of the drug gets absorbed. So orally, this drug doesn't get to very good concentrations in the blood. It is effective for HSV and also for varicella zoster, but it's not effective against latent forms. Now, there is a prodrug version of acyclovir called valacyclovir. This is very well absorbed, then it's converted into acyclovir in your body. That's valacyclovir, much better absorption. That's used. These drugs are very well tolerated. These side effects you see there, they are dose dependent. They're dose dependent. You usually only get them with intravenous acyclovir. With oral acyclovir, oral valacyclovir, you're not going to get them usually. Usually very well tolerated. Okay. Now, pencyclovir is topical. It's used for labial herpes. Famiciclovir is a prodrug form of pencyclovir. So it's converted in your body to pencyclovir. These 4 drugs, famiciclovir, pencyclovir, valacyclovir, acyclovir, they're effective against HSV1, HSV2, and varicella zoster virus. They are not effective against cytomegalovirus. That's why there's goncyclovir. Goncyclovir is effective against cytomegalovirus. This one, however, has some side effects. Causes bone marrow suppression, so check your blood, hepatotoxicity. You can get also mucous membrane irritation. Seizures are not common, but they've been reported. Then there's a prodrug of goncyclovir called valganciclovir. That's oral too. Now, if these viruses become resistant to these drugs, you have 2 options that have a lot of side effects. There's cidofovir and there's foscarnet. These are very effective, but they have a lot of side effects. I'll let you read about the side effects. They're, yeah, not very pleasant to think about. Okay. Influenza meds. There's 4 of them. 2 of them are oral. 1 is inhaled, 1 is parenteral. So oseltamivir, that's Tamiflu. That's oral. These prevent the flu virus from infecting cells. The flu virus has this neuraminidase. They bind on the neuraminidase and gum it up, prevent it from working. So it bounces off the cells. The flu virus cannot infect the cells. Only works early in the infection. Someone's had flu for several days, forget it. So there's oseltamivir. That can cause some pretty serious GI distress. Taking it with food seems to minimize it. Zanamivir is inhaled, comes as an inhaled form. That can exacerbate asthma. Peramivir, well tolerated, but it's parenteral. So you have to go to the doctor and get a shot. Can't just go to the pharmacy, get a pill. You have to go to the doctor and get a shot. Neuropsychiatric events have been reported. Not at all clear if those are linked to the drug. There's a new anti-flu drug called baloxavir. Baloxavir works in a different way. It inhibits the influenza polymerase. Baloxavir seems to be as effective as oseltamivir, but it causes much less gastric distress, at least in clinical trials. It's a fairly new drug, so there's not quite as much known about it. The viral polymerase. And it's the polymerase acid nuclease, so on and so forth. That's part of the polymerase complex. Oh dear. All right, go ahead and read about remdesivir. Very new drug. Many hospitals don't even have it. And it's really expensive. And it only works in the early infection, frankly. Okay. We will finish HIVs, and then go on to blood pressure medicines next. See you Wednesday.